when you get your nasty Smiths and Barton's fractures, just to improve the position of that. We've used it on fifth metacarpal fractures and base of fifth dislocations, or fifth dislocations. Orthopedics will hang them for 20 minutes or so. It just takes out a lot of the spasm, a lot of the muscle tension, a lot of the swelling, and actually it makes manipulation a lot easier for it. So it's not just Colles they're used for. Hand fractures in general if they need an improvement in position.
Yeah.
So yeah, absolutely. So position for the patient is key. So they've got to be sitting upright. So I use an armchair a lot. It's quite nice because you've got to get that kind of nice 90-degree position.
Yeah.
And so sometimes on a trolley when they're kind of slumped down, it's quite difficult to keep that position there. So sitting in a chair, choose your size finger traps. They come in different sizes. Yeah. There's a kind of fairly standard size that fits most people. But if you want to try them out on the other hand, you can see which is the best fit before you put it onto the injured hand.
Okay.
Okay. So we use index and middle finger, but I was saying to Ziggy, that very often thumbs are used as well, but because it kind of gives that kind of tilty position as well. A little bit of deviation. But this works very well with just these two fingers. So index and middle finger, and then I usually get, if I've got someone to help me, just help support the wrist as you're lifting it up. Okay. So then bring the traps up. Ooh, wrong size finger traps for you. Let's try yellow ones. And then just make sure they're right down at the base of the finger. That feels quite snug. Fine. You can put tape on at the base as well, a bit of elastoplast if you want to, just for extra confidence and security. Okay, so hanging at this position here. And then, I should patent these weights. My invention of weights. So 2 kilos is a fairly standard, that's what we tend to use. You can take it down if they're very, very frail and sort of bird-like, or you can up it to 3 kilos if you need to, if they're got quite a lot of muscle bulk, quite big. And this then hangs on the arm just here. Now, this is all about the patient compliance of getting them to relax the shoulder, relax the arm, and let everything go through those fingers. So I spend a lot of time just saying, just drop the shoulder, relax the arm, let everything go through the fingers. So that's the compliance part that you want from them. Because now what this is doing, this is now doing all of your disimpaction. Excellent. So you can kind of, at this point, get them a cup of tea. Just, stand and chat to them if you need to, if they're that kind of person that you just want to stay with them. And within 5 minutes you're seeing big reduction in deformity and swelling.
Interesting.
So you can go away, you can now get your plaster bits all ready. I was saying that if you use stockinette under your wool,
we do put the stocking on first.
I've got it here.
And got one in the
put the stockinette on first before you put the finger traps up, otherwise it's a bit awkward.
That's fair enough. And in terms of pain relief, obviously, you'd still block, would you?
Well, we've had that discussion.
Internox, or because it's so gradual, would you just see what they can tolerate?
Some people are quite stoic and they'll say, I'm absolutely fine, let's just get on with it. When I was at Guildford, we used to use Penthrox and Internox. Down at Chichester, we don't have Penthrox there, so Entonox, they can have some, if they've got a line and some IV Oromorph if they want it, or some IV morphine or Oromorph if you want to give it orally. But actually, a lot of people, what they'll report to you, when they're in this position, it's kind of like a bit like zero gravity in the wrist. It takes away a lot of the pain because their wrist isn't hanging like this. So they get more concerned about, it's quite tight on my fingers. That's the bit they focus on. This doesn't actually hurt too much. So we've changed our process at St Richard's now, that we don't do the manipulation. When we were at Guildford and when I first started at Chichester, I used to do the manipulation while they were hanging. But they now do a Beers block clinic, so they bring all their Colles fractures back into a Beers block clinic to manipulate them under the C arm. But we still use this to do the disimpaction. So So it's still a really important part of that process, but we'll do the manipulation now because I think Niels is quite keen that that process is quite keen to take that process on. So so you can either do it with a full plaster or a back slab. Obviously back slabs don't have the security of a full plaster and manufacturers can slip in and they're not that great, but we've got back slab here, so we'll do the back slab. If I was doing it with full plaster, I'd have the 2 rolls of the 10 centimetre plaster. For putting on 2 rolls is usually enough to put on.
We don't ever do full plasters for.
No, but we used to do that and split them.
Oh, okay.
So you'd have the plaster sort of split them after their X-ray, and actually that was very good. They had to go home and high elevate anyway, but it's just making sure that there was never any problems with that plaster.
Yeah.
When you're putting on the wool, actually I didn't say earlier, it's important that you don't put too much wool on around the wrist, because when you come to then seeing the X-rays, you have a lot of air between the plot. You don't get a good fit, so you really don't need too much around there. Some people used to kind of like put coats on, don't they? It's like, I've got to pad it out, and it's very psychological that you have to kind of like pad it out and.
Get a lot of film material out of this, for sure. Thanks for coming up, Rachel. That's great.
I've got 5 discharges on the screen, so I'm sure you're hunting me down like a dog.
Probably safest place being here.
Yeah.
Safest place being up here.
Yes.
Absolutely.
Well, Eliana put my name on a couple more, and within the last hour the screen is over doubled.
It's exploded,
It's
isn't
just everyone's coming.
Yeah.
It should be
Well, should we go over
20 minutes.
So, plaster on.
Yep. Cut around the thumb.
It's not my best cut-out plaster in the whole wide world.
I was watching you measure up with that paper, and I was like, that's a handy little tip.
Oh.
I do mine by eye, and I'm not bad, but
Oh no, I always use the paper, right? Yeah, I like
Yeah,
that. It's
I
just
like
a.
that.
No,
So-
that's something I thought I'd still think
yeah, I've noted. Yeah,
Because I'm rubbish at that.
incorporate into future practice.
There you go. You see, cross-county sharing.
Yes,
That's what it's all about, isn't
People met
it?
each other, you know, swapping ideas. Great.
That's the way it goes, isn't it? Really.
Yeah, this method of going over the thumb.
Yeah, see, I rip mine. I do the same. Some
Oh
people
yeah,
twist.
you've got to rip your K-band. That's the whole
Some-
point of it. It's lovely.
Some people go over and do the twist over the
Yeah.
thumb.
But it makes it quite bulky up
Yeah,
in there
and
otherwise.
it's quite taut and it pulls down.
Yes.
So I'm quite
You just
happy
rip
with
your,
it.
yeah, rip your little hole there and it works very well. So this is the manipulative part of the process now. So I always just warn patients, this is the bit that's uncomfortable, but it's
Yeah.
only painful as long as it takes for the plaster to set off.
Yeah.
Now you can do it as a one-person technique if you've got somebody else to come in and give you some kind of counter traction on the elbow, because when you're manipulating, the elbow can swing out this way. So you either want to get your knee up on a stool and use your knee, so you can use your knee to push against the elbow, like this, or get some other person to come along and just give you a hand.
Yeah.
You want to disengage the finger traps at this point,
Yeah.
because if you're pushing that way, your fingers
Yeah.
get pulled back. So you can take the weights off.
Yeah.
So take some of the weight out,
Yeah.
and then you're going to kind of lift.
Yeah.
So you're supporting the wrist. I use the heels of my hand.
Yeah.
So hand hand here, and then I use the hand that way, and then I push, and then you can arm deviate at the same time, and then you're just holding it in that position until the plaster sets off.
Okay.
You know, you'll be chatting to the patient at this point, a little bit of distraction about what you're doing, because it is uncomfortable, but they understand what's occurring, and actually compliance is what it's all about, isn't it?
So Jenny, this last part here that you're just demonstrating, this is the one that you currently cutting out with your protocol. You're just doing the traction, and then.
So all we're doing is we're doing a neutral back slab.
Yeah.
So just while they're hanging, there's no tilt and deviation.
It's really unnecessarily complicated. This two-step process, really.
That's that's their
That's
their thing, isn't it? Really. So.
Well, in sort of talking to orthopaedics, they in the Colles that I've done, there was one I did, and one of our consultants was quite keen that actually I did deviate it a bit more. He was like,
sort of bring it right over.
yeah, he said because the risk. This was on a fairly young patient, and the risk of retraction was kind of obviously their muscles are very strong.
Yes.
There's going to be a lot of pull back on that fracture, and he said the deviation actually kind of offsets that and allows it to kind of stay. So you want to overstate the position of the hand.
Sure. I mean, sometimes you see them going out like this, wouldn't you?
Yeah,
it's
I mean
just
that's
ridiculous.
a bit much, but I kind of saw the logic in that.
Yeah.
I was like, okay, that's fair enough.
Absolutely.
So I would probably be very keen to set it like this, because I have seen where they haven't, other casts that haven't really deviated that much, and then they've come back in and it's slipped back.
Yes. Yeah.
Do you think a full cast holds the fracture more stable than
I think
than
so.
a back slab?
I mean, back slabs normally you can do, for some reason at St Richard they've got this thing about doing 5-layer back slabs. I mean, I go for 8.
Yeah.
I think it's a reasonable,
decent kind of.
Yeah, I don't hold. I've done 5 now because I've got the scissors, and it's just ease of, and give your fingers a little wiggle now just to get a bit of life back into them.
Oh, cool.
But there you go.
That's altogether rather easy. Yeah.
It will heal much.
Yeah.
Yeah, okay, feels very comfortable. Yeah. With the back slabs, obviously you kind of do it with the 10-piece. I quite often do it with either the wide 10-piece and a slim, or even 2 slims, and I have an overlap on this point where I've got deviations kind of add to the strength, which means it's at least 10 layers.
Yeah.
So that's why I just only do 5 layers.
Don't even get it. Just
otherwise
upsets
it'll
me.
slip, because otherwise there's still
It upsets
potential
me.
for movement.
Obviously, it's still setting off because the water's cold, but it distresses me hugely. I don't do 5 layers. I don't. I still stick with what I've done all my years, and I'm more than happy with that.
Yeah, exactly.
But that's why I like the full cast to say it's
it's much more stable.
It does work, but you just need to be careful when you're doing the manipulation. You use the flats. Don't use your fingers, otherwise you get your fingertips in. So it's always about using the palms is the best way to do it.
Yeah.
But we were saying earlier that you find your own way, your own technique. If you wanted to, at the point of disimpaction, you think, right, enough now, I'm going to put the plaster on. When the plaster is on before you set it, you can take them out. You can bring the arm down and then do it that way if you want to. There's no reason why you can't do that. But you'll find your own way of doing it.
Yeah, okay, so it's comfortable.
So, yeah.